At its very core, the condition we refer to as hepatitis is an aggressive, acute inflammation of the liver parenchyma. That inflammation can occasionally be triggered by a sudden drop in blood flow from severe ischemic shock or underlying cardiovascular issues like cardiomyopathy. A clinician also has to consider hepatotoxicity. Metabolic disorders or direct poisons, like a paracetamol overdose, can severely damage liver cells. But while toxic and metabolic causes exist in the differential diagnosis, the overwhelming majority of pediatric hepatitis cases are driven by infectious viral agents. There are 5 primary viruses responsible for this disease: hepatitis A, B, C, D, and E. In pediatric medicine, these 5 pathogens follow 2 separate clinical behaviors. The specific route of viral transmission, how the pathogen enters a child's body, determines the severity, timeline, and whether the infection becomes chronic. Categorizing these viruses by their vector allows a clinician to predict whether a child clears the illness in a few weeks or faces a lifelong chronic condition. This chart categorizes the hepatitis viruses, starting on the left with the enteric tract, hepatitis A and hepatitis E. Both of these viruses rely on the fecal-oral route, typically entering the body through the ingestion of contaminated food or water. Because of this direct enteric entry, disease onset is rapid, with an incubation period of 15 to 60 days. Crucially, HAV and HEV lack the genetic mechanisms to establish long-term residency in the liver. If a child's infection stems from an enteric vector, they experience a self-limiting, short-duration illness. Statistically, 95% of these cases make a full recovery. The second, far more dangerous clinical track consists of the parenteral viruses, hepatitis B, C, and D. These pathogens are strictly bloodborne. They require direct fluid contact to establish an infection. Adults often contract these through unsafe injections or sexual contact, but the most frequent mode of parenteral transmission in children is vertical, passed directly from a mother to her child during birth. Within this group, hepatitis D follows a strict rule. It is a defective virus that lacks its own replication machinery, meaning it can only infect a patient who already has an active hepatitis B infection. The clinical consequence of parenteral transmission is severe. These viruses have a high probability of evading the body's clearance mechanisms and establishing a permanent infection. Vertical or bloodborne entry results in a permanent infection, creating a lifelong risk of liver cirrhosis and primary liver cancer. Despite these vastly different long-term trajectories, all symptomatic hepatitis infections share an identical acute physiological phase, starting with a nonspecific prodrome. 1 to 2 weeks before overt liver signs appear, the child typically presents with a fever, general malaise, nausea, and a complete loss of appetite. Beneath these generic symptoms, the liver is undergoing massive hepatocellular injury. We can track this cellular destruction by measuring specific serum transaminases. Looking at this timeline graph, we see AST and ALT levels shoot upward, often surpassing 400 units per liter as the viral load damages the hepatocytes. However, during this initial acute window, the liver's synthetic function holds steady. Markers like serum albumin and PT-INR usually remain perfectly flat and normal, even as transaminases surge. As the acute phase progresses, the classic external symptoms manifest: dark urine, pale stools, and jaundice. But the virus itself isn't directly producing that yellow pigment. The intense inflammation causes individual hepatocytes to bloat and swell outward, physically pinching the surrounding microscopic structure shut. This cellular swelling physically compresses the biliary tract. Mechanical cholestasis stops bile from flowing into the digestive system, forcing bilirubin back into the bloodstream. Cholestatic jaundice is the visual hallmark of the disease, yet up to 35% of all pediatric cases are anecteric, meaning the liver inflames without ever producing the visible yellowing. Ultimately, pediatric jaundice is an indirect mechanical consequence, a localized traffic jam of bile created by a tightly packed, overstuffed liver lobule. The critical divergence between the 2 viral tracks happens at the 6-month mark. Enteric viruses clear out, but parenteral viruses like B and C quietly persist. This clinical slide defines chronic hepatitis as a prolonged necroinflammatory process that continues for 6 months or longer. Over time, the sustained inflammation progresses from mild cholestasis to severe complications, including fluid buildup known as ascites, dangerous coagulopathy, and eventually encephalopathy. Diagnosing this progression requires caution, particularly for infants born to mothers with hepatitis C, because maternal antibodies freely cross the placenta. Testing an infant for hepatitis C antibodies in their first few months will likely yield a false positive from the mother's immune system. Accurate antibody testing must be delayed until the child is over a year old. Misinterpreting those maternal antibodies or failing to track an acute infection past the 6-month threshold allows a parenterally transmitted virus to cause silent, irreversible fibrotic damage to a developing child. Because chronic viral hepatitis lacks a simple pediatric cure, a clinician's primary tool is proactive prevention. Interrupting the chain of infection relies heavily on universal pediatric immunization schedules, specifically the highly effective single and booster doses for hepatitis A and the standard series for hepatitis B. In cases of immediate exposure where vaccines might be contraindicated, administering hepatitis A immunoglobulin provides the child with vital, ready-made antibodies to fight the infection. When evaluating a child with liver inflammation, the diagnostic algorithm starts with tracking the timeline to see if the symptoms resolve or persist past 6 months. This diagnostic flowchart illustrates how we cross-reference that timeline with viral marker testing to pinpoint the exact pathogen and its vector. The clinical rules are clear. Enteric transmission results in acute, self-limiting disease. Parenteral and vertical transmission carry the imminent threat of chronic liver failure. For a pediatric clinician, identifying exactly how a hepatitis virus entered a child's body is the definitive act of predicting the lifelong trajectory of that child's liver.